It's 7 a.m. Dr. Comerota has an OR scheduled today. So in our continuing efforts to try to bring some visiting speakers today, we've got the pleasure of having one of the world's renowned experts on the ilio-femoral DVTs and its management. And Dr. Comerota is going to give us some updates today on some of the new data and some of the new insights into what the clinical trials have shown us. So Tony, take it away.
Well, thank you, Peter. It's a real pleasure to be here this morning, and we're going to talk about the data from the randomized trials, how identifying a primary endpoint may end up leading us down the wrong path if we give too much emphasis to an endpoint that perhaps should not have been chosen. But other secondary endpoints that were prospectively evaluated in the randomized trial showed very clear, important patient care-centered data. And that's basically what I want to try to get across this morning, but also the importance of technique. And I think that when we drill down into the three randomized trials of catheter-directed thrombolysis, when we drill down onto how these patients were actually treated, there's going to be some very important insights that we can gain to improve the care of our patients. These are my disclosures. And we are focusing on ilio-femoral deep venous thrombosis because most of us would agree that for femoral popliteal DVT, the majority of the patients are well treated with anticoagulation. So the trials that we'll be talking about have centered on ilio-femoral deep venous thrombosis and basically address the question, does catheter-directed thrombolysis prevent post-thrombotic syndrome? And I think the answer is, if it's successful, yes, it does. Obviously, if it's unsuccessful, if you don't get rid of the thrombus, it's not going to be much benefit to the patient. So let's begin with looking at some data that were generated by Susan Kahn and her colleagues. Susan may be the world's expert in post-thrombotic syndrome, certainly one of the top few in the world. And they did a prospective observational study of patients with acute deep venous thrombosis. And basically what they found was that patients with ilio-femoral DVT had the most severe post-thrombotic morbidity. And when you look at the odds ratio of 2.23, that, to me, that highlights how frequent this post-thrombotic morbidity is compared to patients with FEMPOP DVT, who, generally speaking, about 30 to 35% of the patients with FEMPOP DVT will have a significant post-thrombotic syndrome. You multiply that by 2.23, and that gives you the percentage of patients with ilio-femoral DVT who have very significant post-thrombotic syndrome. And obviously, that's very meaningful. We're getting up into the 90% range. And Nikos Labropoulos defined the underlying pathophysiology quite nicely as he segmented the venous system and looked at post-thrombotic patients who had calf vein and popliteal clot, femoral popliteal clot, and ilio-femoral clot. And when he looked at these post-thrombotic limbs, he demonstrated that resting venous pressures and post-occlusive hyperemic venous pressures were significantly higher in the patients with ilio-femoral DVT compared to other distribution of deep venous thrombosis. And after all, the underlying pathophysiology is ambulatory venous hypertension in patients with post-thrombotic venous disease, or any patients with chronic venous disease for that matter. So I'm going to show you exactly what ilio-femoral DVT looks like. Not that this audience needs to be shown that, but this happens to be a young woman that we became involved with her care about 6 days after a major operation on her spine for scoliosis. And you can see in the left panel the upper part of the left panel, some of the hardware in her spine. And an ascending phlebogram was performed actually before we got involved. And it fails to show any named vein. All of the veins are occluded. And her clinical presentation was one of relatively acute pain and swelling of her left leg with profound bluish discoloration or cyanosis. So she really had a phlegmatious ruli dolens of her left lower extremity. And this is the ascending phlebogram with its findings. And of course, with the recent operation on her spine, we were not comfortable treating her with catheter-directed thrombolysis, so we opted for a surgical thrombectomy. And here you see the common femoral vein, which is really distended in the transverse venotomy. You see the saphenofemoral junction in the femoral vein there. And interestingly, when the vein is distended like that, it hurts. And if you were to palpate her femoral pulse and palpate the common femoral vein, it's painful for the patients because the vein wall has nerve fibers, and those nerve fibers are really quite distended. But you can see how acute this clot is. She developed it in the hospital within a couple of days of her clinical presentation of phlegmasia. So this clot is not yet adherent to the vein wall. There's no fibrous attachments. And if we just watch this, without manipulating the leg at all, we begin to see that the clot begins to extrude itself because of the exceptionally high venous pressure that these patients have. And this is the thrombus that was retrieved with the venous thrombectomy catheter and manipulation and compression of the lower leg. So fortunately, the venous system was cleared from this clot, but this is an industrial amount of thrombosis. And if this clot is not removed, and if it's permitted to organize, it's going to result in what you see here on the bottom panel, which is collagen. And this collagen is firmly adherent to the vein wall. There's fibrous attachments. And in order to remove that, we generally have to cut it away from the vein wall to remove this persistent endoluminal occlusion if we're going to operate on post-thrombotic veins with severe obstruction. And when we followed this young woman, we were very happy to say that she had normal valve function. She had no edema. She worked as a hairdresser, so she spent the majority of the day on her feet, and we were quite pleased. And this just illustrates that if one is successful in removing the ilio-femoral thrombus, we can expect very good outcomes in many of our patients, if not most of our patients. So to answer that question, does a strategy of thrombus removal result in less post-thrombotic morbidity? I think the answer is yes. The evidence is strong. But when we look at randomized trials, we begin to rethink that. So the evidence doesn't appear to be that strong in the randomized trials. So there are actually 5 randomized trials of patients with ilio-femoral DVT. The Scandinavian Trial randomized patients to venous thrombectomy and anticoagulation versus anticoagulation alone. El-Shawari's trial, catheter-directed thrombolysis versus anticoagulation, but his endpoints were valve function and patency, not clinical endpoints and quality of life. The Kva Trial, the Kva Trial, the Attract Trial are the 3 trials that randomized patients to catheter-directed thrombolysis versus anticoagulation. The Attract Trial integrated a lot of pharmacomechanical, and I emphasize mechanical aspects to thrombus manipulation, in addition to the delivery of a plasminogen activator. And the Kva Trial was basically the same as the Kva Trial, except the Kva trial used ultrasound accelerated thrombolysis, the ECHOS catheter versus anticoagulation. The Kva Trial used a drip catheter versus anticoagulation. And we'll have some interesting observations there. So Gunnar Plata and his colleagues reported the long-term results of venous thrombectomy and a temporary AV fistula versus anticoagulation alone in patients with ilio-femoral DVT. And he reported the 6-month, the 5-year, and 10-year outcomes and demonstrated that in patients who were randomized to thrombectomy, they had improved patency, significantly lower venous pressures, and less leg swelling, and fewer post-thrombotic symptoms if the patients were treated with surgical thrombectomy. And these went out to quite a long time post-operatively, and these are level 1 data. El-Shawari, on the other hand, as mentioned, randomized lysis patients to catheter-directed thrombolysis versus anticoagulation, and demonstrated significantly better long-term patency rates in the ilio-femoral system in those patients randomized to lysis, and significantly better valve function in those patients randomized to lysis versus anticoagulation alone. But as I mentioned, there were no clinical outcomes in his trial. The first catheter-directed thrombolysis trial was published by Tune Enden and our colleagues from Norway, the Kva Trial, evaluating the addition of catheter-directed thrombolysis to anticoagulation versus anticoagulation alone for ilio-femoral DVT. So that was the basic strategy of the trial: additional catheter-directed thrombolysis to anticoagulation for a first-time ilio-femoral DVT. And the primary endpoint was patency of the ilio-femoral venous system at 6 months and post-thrombotic syndrome as measured by the Villalta score at 24 months. And they were looking at whether patients developed any post-thrombotic syndrome. That means a Villalta score of greater than 4. And what they found was that indeed ilio-femoral venous patency was better at 6 months in those patients randomized to additional catheter-directed thrombolysis compared to anticoagulation alone. And that translated into less post-thrombotic morbidity or any post-thrombotic morbidity at 24 months, as you can see, and that was statistically significant. The price to pay was an increased risk of major bleeding, and the catheter-directed thrombolysis patients had a risk of 3.3% of major bleeds. Interestingly, but not surprisingly, ilio-femoral patency and post-thrombotic syndrome were inversely related. The better the patency, the lower the number of patients with post-thrombotic syndrome. So at 2 years, the number needed to treat to prevent one post-thrombotic syndrome was 7. Now, the Kva investigators are to be really congratulated because they followed their patients out to 5 years. And in Norway, you can do that. It's very difficult to do that in the United States with patients moving around and how mobile patients and families are in the United States. But they made an interesting observation. You can see that under the column additional catheter-directed thrombolysis, there was no progression of post-thrombotic syndrome from 2 years to 5 years in the CDT group, whereas there was continuous progression of the severity and the occurrence of post-thrombotic syndrome in the anticoagulation alone group, as you can see, progressed from 56 to 71% at 5 years. And that resulted in a decrease in the number needed to treat to 4 patients to prevent one post-thrombotic syndrome at 5 years if they were randomized to catheter-directed thrombolysis. So that was interesting, and they met their primary endpoint. But what the Kva trial did not show, and I think this is important, did not show a reduction in moderate, did not show a reduction in severe post-thrombotic syndrome. So the patients were getting post-thrombotic syndrome, and it was quite severe. Their primary endpoint was any post-thrombotic syndrome, which for the most part was the mild group. They did not show any reduction in pain or swelling. They did not show any improvement in the quality of life in those patients randomized to CDT. So then we have the Kva Trial, which was performed by the group in the Netherlands, headed up by Kees Wittens. And this trial evaluated 184 patients, first-time ilio-femoral DVT, less than 14 days, as most of the trials are. And as I mentioned, used ultrasound accelerated thrombolysis with the echoes catheter and urokinase as the plasminogen activator versus standard anticoagulation alone. And the primary endpoint was the same, any post-thrombotic syndrome. Their outcome time point was 12 months, as defined by a Volta score of greater than 4. And there was no difference. There was no difference in post-thrombotic syndrome at 12 months in the lytic group versus the standard anticoagulation group, as you see by that p-value. No difference, and there was no difference in the severity of post-thrombotic syndrome. So numerically and in a severity observational mode, there's no difference between the two groups. It's worth noting that 26% of the ultrasound accelerated thrombolysis group were discontinued after the 48-hour venogram showed inadequate lysis. So they're treating these patients for 2 days with the echoes catheter and pretty high dose plasminogen activator, but they didn't notice a difference. And 26% of the patients, one could argue that it was prematurely stopped because at 48 hours, there was no evidence of lysis. I thought that was a fairly high number. So they had a risk of major bleeds of 5%, and that was significant. No difference in recurrences at the 12-month time point, but a very high rate of in-stent thrombosis of 13% in those patients. And a fair number of those patients require stenting to take care of an underlying May-Thurner syndrome or some residual thrombus in the iliac venous system. So the Kva trial, in addition to not meeting the primary endpoint of reduction of any post-thrombotic syndrome, did not show a reduction in moderate post-thrombotic syndrome. Same number of patients having severe post-thrombotic syndrome. There was no reduction in pain, no reduction in swelling, and no improvement in quality of life. And I would argue that moderate and severe post-thrombotic syndrome, pain and swelling, and quality of life are really what's important to patients, not any post-thrombotic syndrome that is not a Volta score of 5 or 6 versus 4, which is basically what any post-thrombotic syndrome means. And as we see, the addition of ultrasound accelerated catheter-directed thrombolysis did not reduce the risk of PTS, didn't alter the patient's quality of life. And I would raise the question of whether ultrasound accelerated thrombolysis actually disadvantages patients who are receiving catheter-directed thrombolysis, because there's a maximum infusion rate of 30, and maybe some catheters 35 cc's per hour, maximum infusion rate with the echoes catheter. And as you'll see, I think the volume per hour of Infusate of a plasminogen activator can make a difference in success versus failure. So that brings us to the ATTRACT trial. It was published in the New England Journal in the end of 2017, and Suresh Vedantam was really the outstanding principal investigator for this trial. It's NIH-sponsored, phase 3. 692 patients with either femoral popliteal DVT or ilio-femoral DVT were randomized to either anticoagulation alone or anticoagulation plus pharmacomechanical catheter-directed thrombolysis. And I do want to emphasize the pharmacomechanical aspect because centers were allowed to use the trellis catheter. They were allowed to use the angiojet catheter in addition to the drip technique of catheter-directed thrombolysis. I want to show the protocol and how it was stratified. And this, I think, is important. The patients who presented with symptomatic proximal DVT were stratified right up front to either ilio-femoral DVT or femoral popliteal DVT. Once they were stratified into one of those two groups, then they were randomized to either anticoagulation alone or catheter-based thrombus removal with pharmacomechanical and catheter-directed thrombolysis techniques. So they were stratified up front. So that permits a valid analysis of ilio-femoral DVT and fem-pop DVT, and the randomization scheme from one group did not affect at all the randomization screen for the other group. So the endpoint was the same for ATTRACT, any post-thrombotic syndrome at 24 months by the Villalta score, meaning a Villalta score of more than 4. And I take a large part of the responsibility for this endpoint, as I was on the steering committee and argued for this endpoint. Just excuse me 1 second, please. Okay, sorry. So in retrospect, I do believe, pardon me, in retrospect, I do believe this was not a good primary endpoint. But we had important secondary endpoints, which were any post-thrombotic syndrome according to the venous clinical severity score, moderate and severe post-thrombotic syndrome, meaning a Villalta score of 10 or more, leg pain and swelling, and quality of life. And I think these are outcomes that are meaningful to patients. Well, in the overall ATTRACT trial, as you can see, there was no difference in the PCDT patients and in the control patients, but this included fem-pop and ilio-femoral DVT. The major bleed rate in the overall cohort was 1.7% versus 0.3% in the anticoagulation alone group, and that was statistically significant. But these results reflect the severity of disease of the patients coming into the trial. And as you'll see, the severity of the disease was not very high in many of the patients, and I'll show you those data in just a second. But I do want to just briefly address the fem-pop patients, just to say that there was no signal at all of benefit from PCDT in the fem-pop patients, but there was an increased risk of major bleed of 3% versus 1.8% in the anticoagulation group. It's interesting that the fem-pop group had higher rates of major bleeding, both in anticoagulation group and in the PCDT group, compared to the ilio-femoral DVT. But I also want to point out to you that in this overall group, 24% of the patients had a normal Villalta score at entry into the study. In my opinion, we should have set a threshold of severity of symptoms before randomizing any patients. But none of the trials have done that. And I think that's an important lesson, because we can't do better. We can't improve on these patients that had a normal Villalta score at entry into the study. So let's look at the endovascular removal of acute ilio-femoral DVT thrombus. And this is from those patients in the ATTRACT trial who had ilio-femoral DVT, still the largest cohort, 391 patients. And the primary endpoints were the same as we discussed. When we look at the results, there was no difference. There was no difference in the Villalta score in the PCDT group with the ilio-femoral DVT or the control group, as you can see. But if we had chosen the venous clinical severity score as the tool to use for the primary endpoint, it would have been a positive study. We chose the Villalta score, and there was a fairly extensive discussion of whether we should use the Villalta score or the VCSS before we started the ATTRACT trial. But we chose the Villalta. Would have been a different outcome, primary outcome, if we chose the VCSS, as you can see. There's some other important information that I think has influenced the outcome of the study, at least in terms of the primary endpoint. And you can see that in the patients who are coming into the study, basically 14% of the patients with ilio-femoral DVT had a normal Villalta score at entry into the trial. And 33% in each group had a mild Villalta score. And I would argue that we can't improve upon their clinical condition because their symptoms were so mild. And you can see the data there. And the question is why? How can this occur? And it's the definition of what ilio-femoral DVT was at entry into the trial. You're seeing both lower extremities in a patient who had ilio-femoral DVT, in patients who had ilio-femoral DVT. The patient on your left had some mild discomfort in the leg, a little bit of swelling in the right leg, as you can appreciate. But her thrombus, she had fempot thrombosis, and she had some clot extending into the common femoral vein, which was non-occlusive. Non-occlusive thrombus in the common femoral vein, which qualified her as an ilio-femoral DVT patient. On the other hand, the patient on your right panel, I mean, he's got a clear-cut phlegmasius ceruleodolens. Interestingly, this was an unprovoked DVT, but he was in terrible pain and discomfort. And when he straightened out his legs, it was even more painful. So you can see that there's an enormous difference in a spectrum of ilio-femoral DVT patients. So we had both of these individuals, and you can see that one has non-occlusive thrombus and the other has extensive occlusive thrombus, resulting in a marked difference in the clinical presentation of each. And in this patient treated, you can see he's got obliteration of his entire ilio-femoral venous system, but with good pharmacomechanical catheter-directed thrombolysis. And this is after 20 hours of treatment. You can see his venous system is open. He has the May-Thurner anatomy. Understand he's in the prone position, so the vein is on the left on the screen. And with correction of that May-Thurner, he has unobstructed venous drainage into the vena cava. And at long-term follow-up, the patient's doing very, very well. And I don't think he would have had this type of outcome with anticoagulation alone. But yet, if you use the primary endpoint for ATTRACT, that's what the primary endpoint would suggest. But as we see, not all ilio-femoral venous DVT patients are the same, and such differences likely impacted the primary outcome. But let's look at these three trials into perspective and in direct comparison with each other. As we mentioned, the Kva trial met the primary endpoint of any post-thrombotic syndrome, any post-thrombotic morbidity using the Villalta score, but no reduction in moderate severe PTS, pain, edema, quality of life. Kva didn't show any benefit for anyone randomized to a CDT. ATTRACT, yeah, we didn't reach the primary endpoint using the Villalta score, but had we chosen the venous clinical severity score, we would have reached the primary endpoint. Instead, this was a secondary endpoint in the ATTRACT trial. But there were important secondary endpoints, which were moderate and severe post-thrombotic syndrome, pain, edema, quality of life, all of which were significantly better in ATTRACT compared to Kva and compared to Kva. And let's look at other details of treatment in these three trials. If we look at infusion time in the ATTRACT trial was 22 hours. Mean infusion time was 48 hours in Kva, 58 hours in Kva. So ATTRACT had much less than half the infusion time of the two other trials. Let's look at the volume of Infusate per hour. In the ATTRACT trial, the volume per hour was a 75 cc's per hour minimum up to 100 cc's an hour versus 30 cc's per hour in the Kva trial, 18 to 25 cc's per hour in the Kva trial. So we're injecting, ATTRACT injected 3 to 4 times the volume of Infusate per hour than the other two trials. So we're saturating the thrombus with the ATTRACT, and with the drip technique, minimizing the volume in the other two trials, I think was disadvantageous. When you look at the overall dose of plasminogen activator, 22 milligrams of TPA was the mean overall dose in ATTRACT, 48 milligrams in the Kva trial, and over 5 million units of urokinase in the Kva trial. Please excuse me for 1 second. Okay, that's the OR. And then when we look at major bleeds, you can see that the ATTRACT trial for ilio-femoral DVT patients, 1.5% compared to 5% in the Kva trial and 3.3% in the Kva trial. So I think this shows very clearly that technique matters. The way we deliver the plasminogen activator matters significantly. If we can increase the surface area of the thrombus, that would be very important. And we do that with mechanical manipulation of the thrombus, using pulse spray, using the trellis catheter. And now we have other catheters coming on the market that do this very well. High volume infusion is important. Saturating the thrombus with the plasminogen activator solution is important compared to low volume infusion. And we don't need large doses of plasminogen activator. A low dose of plasminogen activator dissolved in a high volume will achieve our goal and significantly reduce the risk of bleeding. Precision infusion of the plasminogen activator is important, and that basically results in improved efficacy and safety. So compared to no pharmacomechanical catheter-directed thrombolysis, as we saw in ATTRACT, there was a significant reduction in any PTS using the venous clinical severity score, significant reduction in moderate and severe post-thrombotic syndrome, reduction in pain and swelling, and significant improvement in disease-specific quality of life with PCDT compared to controls, as we see with the ATTRACT. Well, with an historically low risk of major bleeding. Well, thanks very much. I'd be happy to entertain any questions.
So thank you, Tony. That was really wonderful. So one of my questions is, when I read all three of the trials, all of them had a significant amount of thrombus burden. In other words, if I recall correctly, Kva had up to 35–40% of the people who still had 50% luminal reduction. So what's your feeling about thrombus burden? And you alluded in your last comment to the new catheters that are out there. My suspicion is, with the newer technologies and leaving less thrombus burden behind, I think some of these clinical endpoints might change a little bit. What are your feelings about that?
Yeah, I agree entirely. Thrombus burden is important. We see that in pulmonary embolism as well as DVT. The more thrombus burden you leave behind, the greater the risk of recurrent thrombosis, and that was shown very nicely by a meta-analysis by Russell Hull a number of years ago. But restoring patency and restoring unobstructed venous drainage really should be the goal that we hope to achieve. And
my last question is in regards to another fact that you mentioned about the very low stent rate in all three of the trials. So what's your feeling about that? Were they leaving behind residual stenoses in a lot of these patients? Why you think the stent rate was so low in these patients?
Yeah, Peter, I think we left that, of course, up to the investigator.
Okay.
And my impression is that many patients deserve the stent, and if they were treated by us, they probably would have received the stent. And I'm sure if they were treated by Suresh, would probably have received the stent versus the fact that they didn't in other environments. I think those patients were likely to be undertreated when we look at our ilio-femoral DVT population.
All right, listen, I know Dr. Comerota, the OR, is waiting for him. Does anybody else have any questions for him? Because otherwise I'd like to let him go so as people don't keep bothering him.
Thank you very much.
Thanks, everybody. Thanks, Peter.
All right, Tim, you all, thank you so much. I really appreciate your time.
Good weekend, everybody.
You too. Take care.
Thank you.